Buenas noches, profesores y compañeros IDVI del Diplomado Apolo 1. Somos el equipo 4, conformado por la doctora Miriam Torres, la doctora Paulina Carreño, el doctor Rodrigo Vázquez, el doctor Juan Manuel Gómez. En esta ocasión queremos compartir con ustedes esta interesante presentación del doctor Víctor Barco. Él es profesor de medicina en el Departamento de Neurología de la Universidad de California en San Francisco. Su trabajo clínico y de investigación ha estado centrado en disciplinas sobre envejecimiento y desórdenes cerebrales en VIH. Sus líneas de investigación principales están relacionadas con demencia en VIH crónico y padecimientos cognitivos relacionados. Esta presentación aborda interesantes puntos relacionados con la función cognitiva y el envejecimiento en VIH. Esperamos que sea de su interés.
I always worry that, in fact, our elders are going to be the last people to be engaged in any of those studies. And certainly it's a population we need to think about carefully and how we can maximize their outcomes. Today I'm going to speak about 4 things, and I'll be very quick through some of them. The epidemiology of HIV, I think I'll speak about quickly. I wanted to go through some geriatric tenets that could be useful in HIV. I have only one slide trying to convince you that cognitive impairment remains important. Fortunately, Dr. Spudich this morning showed some slides that I might choose to show about immune activation. And then I thought I'd tell you about an emerging challenge we have in geriatric HIV. And for those stream, please don't be on the live stream. Please don't give away the answers. Aging is not just an HIV phenomenon. It's a world phenomenon. And here in the red is an indication of the aging populations in low, middle-income countries compared to those that are not. In the next 30 years, aging will become a true issue around the world, and particularly in countries that don't have a lot of economic capability to provide support for elders as they become more frail. That's not happening here in Thailand either. If you look at 1960, here in your upper left-hand corner, you can see that those in the older age groups really are a smaller proportion to the population. But this is where we're heading. So, in fact, this has an implication economically that the number of people in the workforce supporting elders who are not in the workforce is changing tremendously. We call that, we look at that ratio specifically for economic burden and really challenges for resources within a region that may require more assistance in caring for elders and hospitalized elders particularly. HIV aging is really a phenomenon that's occurred mostly in developed countries, but even this slide from Africa indicating here the increasing redness over time, that particularly in sub-Saharan Africa, South Africa, the rate of people living with HIV over 50 is increasing tremendously. But indeed, as I just said, it's mostly occurring at this time in developed countries. Southeast Asia here showing an uptick in the frequency. This is a slide that dates back about 5 years. But the question is also, who cares and how are we going to work with this? For a long time, the aging research community was obsessed with the idea of accelerated aging and markers of accelerated aging. And I think a lot of the people who are driving that have now moved on to cure to the benefit of the patients who are aging with HIV, because although we could use HIV as a model for accelerated aging, really what we want to get to is how do we get this frail elder to the hospital and back in good condition, healthy, and having a good quality of life? How do we want to manage to extend quality of life expectancy for these elders? And this is the approach that I'm much more keen on than trying to find the fountain of youth in people who are living with HIV as a chronic illness. So you might ask, which geriatric principle would be useful as a construct in geriatric HIV? And I'm going to give you a few seconds to just vote on that. Which of these concepts do you think is interesting for geriatric HIV? Geriatric syndromes, frailty, multi-morbidity, or would you go with none of the above? Hopefully people downloaded the app, or we'll see like 1 or 2, and I know who it is. It's actually just a question of futility. I want to know how many people say none. Or even awake and vote at all. Maybe people did watch me on live streamed a few minutes ago, and these are all going to not work out. I would tend to agree with this very much so. I think when you're talking about the population that is aged with HIV right now, the constructs of geriatric syndromes and frailty are not working as well as just considering the interaction of diseases as we look at particularly middle-aged people. Let me tell you just a couple things that I know about being older and taking care of people that are older. This is a slide of me back in 2000, I don't know, or maybe 2001. I was working in Hawaii at the time. I looked a lot younger. I didn't have gray hair. And I was taking care of people over 50 years of age living with HIV. This woman agreed to be on the front page of the local paper with me and was living with HIV at the time and doing well, I would say, overall. Not a lot of morbidity. And then later there was this publication in the New York Times of a very frail individual who had multiple diseases that were occurring, things that you don't tend to see in non-HIV infected populations, like avascular necrosis with bilateral hip replacements. And the point that I would take from these two pictures is just what I've written here. The variability in old age is greater than the variability across ages. And what I mean by that is you can't simply go by chronological age to determine how frail or how vulnerable a person it is. It just doesn't work that way. We've all seen people who are 90, 95 years of age. I've cared for patients who are smarter than I am at 95 years of age, more alert than I am. A person that I gave a flu shot to, even though she insisted she'd had one, and 2 weeks later I realized that in fact she had. There's a really robust aging that can occur, and then there's a very frail aging that occurs. And so there's a lot of variability that makes it almost useful to have some kind of a way to categorize that. People have looked at these syndromes that occur in geriatric, in old populations, and some of the syndromes can include things as simple as weight loss and low activity and weakness. As a consequence, they've kind of moved them into this construct of frailty. And when frailty was initially defined, it was defined in very old populations, people over 80 years of age who were not doing very well, and we couldn't tell why they weren't doing well. It wasn't any of the specific diseases, and we couldn't pin it on anything. We'd maximize treatment for everything, and still they were doing well. So people wanted a model of how in that setting can you predict bad outcomes and vulnerability. It's not about a specific disease, but it's across a number of different diseases. And I would say the word I use is a biological vulnerability. People who tend to have bad outcomes, but without having a clear reason why they're having bad outcomes. In clinical practice, this has turned out to be fairly useful. It can predict people who are going to have challenging hospitalizations, and it can help us identify the types of people that may need more interventions. In research, it's been helpful in late life and particularly in end of life. But in HIV, I think it's really failed us to date. First of all, the frailty phenotype does associate with some of the biological factors of HIV, but they don't seem to add terribly on top of the factors that we already have. And the most critical challenge is that it's not very frequent in the populations where it's been studied. It tends to occur in less than 10%. So people have started talking about a pre-frailty phenotype where you only have to meet one of the criteria, and the criteria are things like weakened hand grip strength or slowness in movement. So I found it rather difficult to use. Perhaps I'm biased as well, because the biggest determinant of a bad outcome in an elder person is the degree to which they have cognitive impairment. We know, in fact, that that's the leading reason why people are hospitalized, yet most frailty indices don't use that, a construct of any cognitive impairment whatsoever. We've tended to look a little bit at these syndromes independently, and here are some of the common syndromes that people have tried to quantify in old age. The construct of a syndrome is that, unlike a disease where you might have a clear biological issue that's causing very clear symptoms and signs that are associated with it, and you target the disease to try to treat all of these signs and symptoms that occur, in the setting of understanding a geriatric syndrome, you almost flip that and you say, we have a number of different things that are contributing to really what the bad outcome in this case is delirium. But delirium is not caused by one specific disease. So people have tried to use this in this setting as well. It does provide a framework for multiple contributing etiologies to one bad outcome. And it focuses your care on function rather than trying to treat any of the individual diseases. For example, you may have somebody who has hip fracture, and instead of really going after the hip fracture itself, you begin to think how this is limiting the individual and how they can be helped through functional approaches. For example, trying to move the bedroom down onto the first floor so they don't have to go upstairs. What's really helpful about these syndromes is it recognizes that poor outcomes may be more than just one individual disease, which is what you would typically see in a younger population. And when you quantify this in people over 50 years of age with HIV, you indeed find uptake of a lot of these. Falls, for example, are frequently indicated. Well, the falls could be because they have neuropathy, it could be because they have some cognitive impairment, or in fact it could be because they're on benzodiazepines or sleepers, having difficulty sleep at night. There are a number of different etiologies for it, and you can begin to unravel it by understanding how often it occurs. Likewise with urinary incontinence and even functional limitations. So there's been some benefit to trying to quantify these. The most common syndrome is polypharmacy. And polypharmacy occurs quite often. I had a question in here, but I didn't have enough supportive slides, so I'll just tell you the punchline here is that although the number of antiretroviral medications has decreased over the past decades, the total number of medications has increased. And the number of inappropriate medications that are prescribed when you look at the lexicon database is higher in HIV-positive patients than HIV-negative patients who are similar of age. And we also looked at the anticholinergic index, which is an index of how these drugs affect the acetylcholine system in the brain, and find that it's elevated, and that could contribute to cognitive impairment. And of course, when you have polypharmacy, one of the biggest challenges is that you have drug-drug interactions that sometimes you don't know about. What was striking to me when we looked at these 87 people is cumulatively they were on well over 1,000 medications, which is a tremendous number of medications in elders. I'm going to quickly pass through multi-morbidity because Dr. Rice is going to speak about it in more detail, but I think it has some clinical importance, and I'm glad to see that the group here thinks so as well. The concept of multi-morbidity is really more than comorbidity. It's not that you have 1, 2, or 3 different diseases. It's the fact that these 1, 2, 3, and 4 diseases interact with each other to cause synergistic or additive qualities that exceed what you would expect by just counting the individual diseases. It's a measure of cumulative injury on major organ systems in the body. The VAX index is probably the best approach that has been taken to try to quantify this, where in addition to CD4 cell count and viral load, as well as hepatitis C serology, they begin to add on anemia, kidney function, and liver function to see if there's a cumulative index that can help identify people who are most at risk for bad outcomes. The most striking thing about it is that it correlates strongly with inflammatory factors. And then in my work in cognitive impairment, it also correlates with the degree to which people have cognitive impairment, probably because of an epiphenomenon with the degree of inflammation that correlates to both of these diseases. Really, when you think about the heterogeneity in old age, we hope that most people are here on your left, that they have few health outcome problems and they have a robust life. But there are much fewer people here in the frail and vulnerable side. And really what we try to do in our work is take this arrow and turn it around. It does appear that HIV is causing us to move this curve with fewer people who have fewer health outcome problems and more that begin to have multiple medical problems. But our goal really should be to try to push that over. And a slide that I cannot speak about aging without showing this seminal slide that was published back in 1980. That anyone who's trained in geriatric medicine has seen at least one time. But the goal in a lot of what we do is try to compress morbidity. So indeed, if this is your functional life expectancy and you're going along at 100% and you're doing wonderfully, life is great, fantastic, and then suddenly you were hit by a truck and you go to 0, that's probably an optimal outcome. although I don't want anyone to get hit by a truck until they're ready. But you want to keep the curve as high as you can for as long as you can. Yet some of our HIV patients are beginning to have a curve that looks more like this, where they're carrying multimorbidity, and the goal really is to try to push this curve over. And we can do that in many ways without medications by trying to look at the global functional outcome of individuals. I really don't have time to talk a lot about the persistence of cognitive impairment, but let me ask you as a group, cognitive impairment among patients who adhere to antiretroviral therapy and maintain suppression, these are your optimal outcomes. People completely suppress plasma outcome, then the cognitive impairment that we see is completely due to comorbidity. That's what I'd like to ask you. Essentially, I'm asking if there's an HIV component. So people who are suppressed on antiretroviral medications, then the etiology to cognitive impairment is due to other diseases. Yes or no? True or false? This is, 30 seconds is too long. 15 seconds, we should go next time. Maybe people have to get the app. So most people are saying that it's true, and there are quite a few people that are saying that indeed it's false. And this is probably a very accurate outcome because it's probably in some ways a mixed bag. The frequency of cognitive impairment after we treat it with antiretrovirals remains about 50%. So even when antiretrovirals are available, 50% of the population has cognitive impairment. The real challenging thing about this number that always infuriates me is that the 50% with cognitive impairment after heart, less than 50% of those people were suppressed in the paper that's being cited. So people don't tend to look at an optimally treated population to inform their science. This is something that we've really pushed heavily in meetings and we do in our own lab, is that we try to understand what is happening in people who are suppressed. And the key take-home point that I would want all of you to know is there are excellent data showing that if you are completely suppressed with antiretroviral therapy, you continue to have immune activation in the brain, demonstrating microglial activation. Dr. Sputich mentioned this morning. And that microglial activation is almost certainly due to HIV, somehow continuing to cause a degree of inflammation. So there is absolutely no doubt in my mind that we are not sufficiently treating people to remove all risk for cognitive impairment. Having said that, when you look carefully at papers, comorbidity is a strong influencer of cognitive outcomes. So it is in some way a mixed bag. But don't leave this meeting thinking that it's all comorbidities when you see your patients. I think that's a disservice to them. I think there's truly an HIV component that continues. This brings me into what I want to end my talk about, is really what I spend most of my time thinking about, is what's happening in the brain. And I call this the most pressing geriatric neuro-HIV challenge. And I'm thinking particularly about geriatric, meaning over 65 years of age, which is the group that I study in San Francisco, people who are truly in a geriatric population. Well, why does that matter? It's critical when we talk about the brain, because if you're thinking about diseases like Alzheimer's disease, they simply don't exist with any frequency in 55 to 60-year-olds. Maybe 0.5% of the population will have an Alzheimer's syndrome. So people who are looking at models of accelerated brain damage that may indicate some level of neurodegenerative disorder that's age-associated, yet they're looking at people who are in their 50s, are really not looking at a vulnerable population for this. And so we've pushed the envelope to try to look at people who are older. And there's a lot of reason to believe this is what the curve looks like in Alzheimer's disease. It doubles every 5 years, so that your risk is about 1% at 60, 65. But by the time you're 70, 75, it's up to 5 or 10%. And by the time you're over 80, your risk for having Alzheimer's disease in the general population is around 25 to 30%. So it goes up exponentially. And there's a very good model of cerebrovascular disease with Alzheimer's disease that shows that you can move this curve up if you have more than one disease. Well, our HIV patients tend to have 3 diseases. If they have Alzheimer's disease, that would be their first, if they do. The second is cerebrovascular disease, because there's a tremendous amount of cerebrovascular disease in aging HIV patients. And the third is that they have an inflammatory phenotype that could increase their risk for Alzheimer's disease. A paper was published last year showing for the first time, this is how the public relations group at the university advertised this, not the paper, which was much more balanced. For the first time, doctors identify a patient with both Alzheimer's disease and HIV. I can tell you that people who work in memory clinics and see HIV patients have diagnosed this disorder for many years now in some of our older patients living with HIV. But this got a lot of press because it was an individual who was older and developed Alzheimer's disease in the setting of HIV. What was really interesting about this paper is there was a 2-year delay in making his diagnosis, which tells you a little bit about the frequency in which cognitive impairment occurs in HIV and how HIV patients are really at the greatest risk to have a delayed diagnosis for Alzheimer's disease because their symptoms may be brushed off. In this study, they diagnosed Alzheimer's disease in the individual by looking at a PET ligand that picks up amyloid, the key protein that's deposited in the brain during Alzheimer's disease. And in these images, there was uptake of this amyloid that was consistent with the diagnosis of Alzheimer's disease. This is actually probably a very good way to diagnose Alzheimer's disease in older HIV. In my setting, it costs about $4,000 to $5,000 a scan, so it's not a practical approach to doing it. We've begun to look at this a lot, and I've had a lot of individuals who really give me pause about this, and I'll tell you about one that we saw last year. He was 72 years old, right-handed, 18 years of education. He had been diagnosed with HIV in the 1980s with a nadir that was not terribly low, 300, and his CD4 cell currently was almost 700. He was undetectable, and he was on antiretrovirals, which I've shown you here with an integrase inhibitor-based regimen. He'd not had a lot of comorbidities. He had Kaposi sarcoma in 2003, and he had hyperlipidemia. He came to see us because he'd had subtle decline in memory and executive functioning. Executive functioning being the patterns of thinking and cognition that are required for you to do complex tasks. He had really not had functional impairment at this time, but he was terribly worried that he had Alzheimer's disease. He had depression that was under treatment, and he'd had it for a long time. He thought it was under good control, and although he had some sleep problems, he was sleeping relatively well overall. We did cognitive testing with a MoCA, which many of you may be familiar with. He scored 24, so he was in the mild cognitive impairment stage, the stage that I think is at most risk for not diagnosing Alzheimer's disease, because once it progresses, it becomes a little bit more clear. But it's not very hard to understand that there's something terribly wrong with this clock. The numbers are backwards. The hands are really not in any clarity. And there's really a visual spatial challenge that we see in both HIV and Alzheimer's disease. But this is unusual. We don't usually see clocks that bad in HIV. And it gave me certainly some concern. When we did a more thorough cognitive testing battery on him, more worry for me. He had true memory problem, visual memory problem. And unlike nearly every HIV patient I've ever seen, he had trouble with language. He was having trouble with categorical fluency. He was having difficulty naming things. So we show him pictures of things, and he should have done well with a master's degree in English language learning. But he was really having problems in an area of thinking that I tend to think of as being spared in HIV. Of course, he also had quite a bit of motor problems here that would be more consistent with HIV. He had some challenge with a sequencing task we call the Lurie sequence. He had some neuropathy that we could identify in his lower extremities. And what worried him the most is he was in his early 70s, and his brother had died of Alzheimer's disease at his age, a little younger. So he was worried. He has a strong family history. This is a worrisome family history for developing Alzheimer's disease himself. So we imaged him, and his image was rather normal. It was read as normal. I reviewed it. I didn't see any focal atrophy. What do you do in the clinic? Now, you're all faced with this challenge. I'm going to start the voting a little early and keep talking because it's so long. What do you do here? Do you do a lumbar puncture on him to see if additional testing can be done? Do you treat for both Alzheimer's disease and HIV, the second choice? Or do you just treat for HIV and just watch to see if he gets worse? What do you do? 1, 2, or 3? Not a lot of choices. I suppose if you don't want to do any, you can just refuse to vote. So, lumbar puncture. Well, this is a reasonable thing to do. I mean, it's a worrisome picture. I can tell you that the duration of his symptoms were quite long, 10 years. I didn't make that quite as clear. And it's worth looking perhaps to see if he has virus in his CSF. Very rare event. Very rare event to see if he has CSF escape. You could do that if you wanted to. You could also measure amyloid and tau in his CSF. Those are markers for Alzheimer's disease. Unfortunately, they're perturbed in a setting of inflammation. Amyloid tends to be dropped. The last person I did an amyloid and tau measure on in CSF, it came back equivocal because his amyloid was low and the tau was normal. It wasn't consistent with Alzheimer's disease. Unfortunately, neuroinflammatory disorders have a problem with this. Well, there's a lot of literature to tell us that, in fact, we could do better with this. If you look at the cognitive testing scores, and you compare this very busy slide, and I apologize, if you compare the cognitive testing scores of HIV and AD, clear patterns, at least historically, that you can differentiate these two. Motor changes are different in the two, and we even find differences in behavior. If we start looking at imaging, we should be able to see focal atrophy, which this individual didn't have. But we should be able to use some of those measures to do it. ApoE4, probably not useful at all. Amyloid and tau, probably not useful in CSF, although we'd like to test that in an appropriate population. I can tell you that we've done some machine learning work comparing people with an MCI from Alzheimer's disease with people with HIV-associated cognitive impairment. And with 95% accuracy, using the imaging alone, we could differentiate these two groups. So I think it's quite possible that we can use imaging to distinguish HIV-associated cognitive impairment with Alzheimer's disease, particularly if we add on some cognitive stuff. So I didn't give you the answer on this gentleman. We were fortunate enough to co-enroll him in a study where we could measure amyloid in his brain. And indeed, he did not have amyloid in his brain. He did not have Alzheimer's disease. So he has an HIV-related cognitive impairment. I can also tell you that he was so relieved when he heard about that, he would not let us do a lumbar puncture. So we haven't worked him up any further. He really thought, and I did too, that he had Alzheimer's disease.